Hello everyone, my name is Swati and today I will be taking a topic of placenta previa and I hope I make it easy and understandable for everyone. Starting with the topic, before understanding actually what is placenta previa, we must first know that placenta previa is actually a subtopic under the broad umbrella of antepartum hemorrhage. Okay, so I will take a few minutes to explain about what is antepartum hemorrhage. So starting with the definition, antepartum hemorrhage is defined as bleeding from or into the genital tract after 28th week of pregnancy but before the birth of the baby. Okay, so in this definition there are two things which we need to remember. Okay, one is after 28th week. Why is it very important is if it is not 28th week, if it happens before 28th week, it will not come under antepartum hemorrhage, rather it will be a type of abortion. Okay, and the second thing which we should remember from this definition is before the birth of the baby. Why? Because if the bleeding happens after the birth of the baby, it is no longer considered as antepartum hemorrhage, rather it will be a type of postpartum hemorrhage. Okay, so what we should remember in antepartum hemorrhage is bleeding after 28th week of pregnancy but before the birth of the baby. Okay, now we will understand quickly about what are the types of antepartum hemorrhage. Okay, so antepartum hemorrhage is broadly categorized in three types. Okay, one is placental bleeding, which includes like 70% of all the antepartum hemorrhages are because of placental origin. Okay, 25% of antepartum hemorrhage are unexplained. That means we don't know what are the reasons. And the 5% of placental bleed of antepartum hemorrhages are extraplacental. That means it is associated with any kind of lesions like a vaginal lesion or cervical polyp or carcinoma of the cervix or any kind of local trauma to the genital tract and varicose vein. Okay, so what is important to understand in this classification is out of all the antepartum hemorrhages, 70%, that is the majority of the bleeding, is placental origin. Okay, that is 70%, and out of that 70%, 35% is because of placenta previa and another 35% is because of abruptio placenta. Now coming to our actual topic for today, that is placenta previa, starting with the definition. So when the placenta is implanted partially or completely in the lower uterine segment, it is called placenta previa. Okay, so if you are a medical personnel or you belong to any health sector, you might be clear with the term previa. Okay, previa means before. So placenta previa, if you take it verbally, what it means is before. Placenta comes before. Okay, which is on the contrary to what happens in a normal pregnancy. Because in a normal pregnancy, what is supposed to happen is the baby comes first and the placenta comes later. Whereas in this situation, in placenta previa, it happens exactly the opposite. That means the placenta is situated in the lower uterine segment and baby is in the upper uterine segment. Okay, hence causing this complication. So once again, the definition is when the placenta is implanted partially or completely in the lower uterine segment, it is called placenta previa. So here is a small image for a clear understanding of the topic. If you see the image on your left hand side, what you can see is a normal pregnancy. So you can find that placenta is attached in the upper uterine segment. So whenever the cervix will start to dilate, okay, so baby will be delivered first and later on it will be followed by the placenta. Whereas if you see the image on the left right hand side, what you can find is the placenta is situated in the lower uterine segment. So in this scenario, what complications can happen is because the placenta is in the lower uterine segment, it is more prone to any kind of injuries and bleeding is a risk. Okay, and also where if the cervix starts to dilate, the placenta will start to detach before the baby is born, leading to heavy hemorrhage, which is an extremely fatal condition for mother and the baby. Now, starting with the incidence of placenta previa. if you say take it globally, 1 of every 250 births is reported as placenta previa, and if we take in India, it is 1 in 200. Okay, that means one third of all the antepartum hemorrhage occurs due to placenta previa. So next, let us see what are the causes of placenta previa. Okay, so we should understand that the actual cause of placenta previa is not known, but there are certain theories which tries to prove why it happens in some of the women. The first theory is the dropping down theory. Okay, so what it says, dropping down, from the name, what we can understand is the fertilized ovum drops down into the lower uterine segment. Okay, so we all know that the fertilization takes place in the fallopian tube, and when the fertilized ovum travels to the uterine cavity, normally it is supposed to implant itself in the upper uterine segment. But in certain conditions, when the endometrial reaction is not proper, it may drop down. The fertilized ovum drops down and it implants itself into the lower uterine segment, which can lead to placenta previa. Okay. And the second theory is the theory of multiple pregnancy, which says that if a lady is carrying more than one baby, so what happens, because there are two babies or more than two babies, the requirement of baby's food and nutrition and all the things is more, leading to bigger size of the placenta. And because the placenta is bigger in size, it can come from upper segment to the lower segment because it covers a bigger surface area. Okay, that is what multiple pregnancy theory suggests. Okay, and the last theory is defective decidua. So what does it say is defective decidua? What is decidua? Decidua is the endometrium of a pregnant lady. Okay, the endometrium of a pregnant lady is known as decidua. Defective decidua theory, it suggests that when the endometrium is not functioning properly and it fails to stop the growth of placenta, which can lead to overgrowth of placenta, and hence the placenta approaches the lower uterine segment. Now, moving forward to what are the types of placenta previa. Okay, so it is also known as degrees of placenta previa. Types or degrees of placenta previa means the same thing. There are basically four types of placenta previa. They are categorized as type 1, also known as lateral, type 2, known as marginal, type 3, known as partial, and type 4, known as complete. Okay, so let's deal with it one by one. The first one being the lateral or type 1 placenta previa. What does it mean? The lower margin of placenta dips into the lower uterine segment. That means only the margins of placenta are reaching the lower uterine segment, but it is not covering the os. Okay, so it is nowhere near the os. It is just in the lower uterine segment. Okay, so that means it is the least dangerous one. Type 1 is the least dangerous one. Okay, going to type 2, also known as marginal. In this type, the placenta reaches the internal os when it's closed but does not cover it. That means when the os of the cervix is closed, in type 2 placenta previa, the placenta reaches the internal os, okay, but it does not cover it. So that is also not that risky, okay, as compared to type 3 and type 4. Now, starting with type 3 and type 4, these are the one where the risk actually starts. Okay, the risk is higher on these two types. What is type 3? In type 3, the placenta covers the os when closed, but not when fully dilated. Okay, also from the name partial, what we can understand is the placenta is lying over the os when it is closed. Okay, but when it starts to dilate, it will not completely cover it, but only partially it will cover it, but still there is a risk of bleeding. Okay, and the last one, type 4, or the most critical and fatal one, that is central or complete. What happens in this? The placenta is actually situated on the os. Okay, so even when the cervix is fully dilated, the placenta still covers the os. So this will become more clear to you if you can see this image. The first one, if you start from your right hand side, the first one is the low lying placenta. You see this one. So what is happening? The placenta is simply in the lower uterine segment, but it is not reaching anywhere near the os. Okay, and the second one, that is a marginal type 2. What is happening in this? You can see the margins of placenta are reaching the margins of os, but it is not covering it. Okay. And if you see the type 3 or partial one, you can see that the placenta is covering the os. Okay, it is covering the os when it is closed, but when it starts to dilate, it will not be covering it. So it is partial. Okay, and this is the complete one, in which you see the placenta is actually situated over the os. So even when the os will dilate and the cervix is fully dilated, the placenta is still over the os. Now let us discuss about the predisposing factors or the risk factors. Okay. So the first risk factor for placenta previa is the increased placental size, which happens in case of twin pregnancies. Okay, and the second risk factor is previous uterine scar, which happens if the lady has earlier gone through any kind of uterine surgeries or she's having any kind of uterine scars. There is a tendency that the placenta will attach itself on the uterine scar and can cause placenta previa. Okay. Third risk factor is multiparity, which is of course the same thing as more than one babies, which leads to a bigger size of placenta, which spreads down to the lower uterine segment as well. And the last one is advanced maternal age. So how does advanced maternal age affects in placenta previa? Is because as the age of lady increases, there's a chances of defective decidual activities. If you remember about the theories of defective decidua, what I said there is when the decidua or the endometrium is unable to stop the growth of placenta, it can lead to placenta previa. That is the same thing which happens in the case of advanced maternal age. Continuation of the predisposing factors is if the lady has undergone any previous reproductive surgeries like dilatation and curettage, it can also lead to placenta previa in future pregnancies. Okay. And leiomyomas distorting the uterine cavities, that is actually a type of benign tumors growing in the endometrial linings of the uterus, can lead to placenta previa because there is a lack of space in the uterus. As there is a growing tumor inside the uterus, it can lead to placenta previa. And the last predisposing factor is a congenitally malformed uterus. The lady is having any sort of congenitally malformed uterus, there is a risk of placenta previa. Now let's start with what are the signs of placenta previa. So the first and foremost and the most important sign of placenta previa is painless vaginal bleeding in the third trimester of pregnancy. Why we are saying third trimester is because we discussed in the definition itself that it has to be 28th week of pregnancy. Okay, so if a lady is having painless vaginal bleeding in the third trimester, that signals the chances of placenta previa. Okay, and the bleeding is usually bright red. Why it is important to notice here the blood is bright red is because it is a fresh blood coming out of the suppression site of placenta in the endometrium. So the blood is always bright red. And the next sign is the bleeding may be scanty at first and then becomes more and more profuse. So at first when you see the bleeding will be less, then later on as the time passes the bleeding will become more and more profuse because the suppression is increasing, and as the suppression is increasing the bleeding will also increase. Okay, and next sign is there is no way that bleeding from the placenta can be arrested. Okay, so if it is actually the bleeding from a placental suppression site, there is no way you can arrest it by giving the lady rest or elevating the foot end or anything. Whatever you try, this is very difficult to arrest the bleeding occurring from the placental previa site. Now let's discuss what are the risk to mother and the fetus, starting with the risk of mothers. First risk is severe hemorrhage. Okay, that is the commonest one, the risk of severe hemorrhage. And the next is embolism. There's a chances of embolism, risk of embolism associated with placenta previa. Okay. And next comes the endometritis, that is the inflammation of the endometrial lining, that is also risk associated with placenta previa. And what the risk for the baby is, first is the chances of prematurity, because as we have discussed in placenta previa, once the bleeding starts there is no way you can arrest the bleeding, so the ultimate way to cure it is to deliver the baby, which can lead to prematurity and the complications associated with premature delivery. And the second risk for babies is asphyxia. As we know that the placenta is a bridge between the mother and the baby receives its oxygen and all the supplies with the placenta. If placenta separates, there's a chances that the baby becomes asphyxiated due to lack of oxygen. And the next risk factor for baby is risk of hemorrhage. Why the risk of hemorrhage is basically because of operative deliveries, okay, because the mother has to undergo operative delivery, so chances of hemorrhage is more for the baby. Okay, moving forward with the diagnosis of placenta previa. The ultrasonography gives a very accurate information about the placement of placenta, and hence early diagnosis of placenta previa is very much possible with the help of ultrasonography. Other than that, we can also use magnetic resonance imaging or MRI scan for diagnosis of placenta previa, but it's a bit expensive as compared to ultrasound, so it's not regularly used in a clinical setup. Now, moving forward with what are the complications of placenta previa, it is basically divided into two: maternal complications and fetal complications. And the maternal complication is again subdivided into three, that is during pregnancy, during labor, and during puerperium. Okay, so we'll deal with it one by one. So the maternal complication during pregnancy, the first and foremost is shock, which is basically hemorrhagic shock, which happens because of excessive bleeding if in case the placenta separates prematurely. And the second complication is malpresentation, which is very common in placenta previa because the placenta is occupying the lower space, so baby pretty much goes into breech presentation whenever there is a placenta previa. And the third complication of pregnancy is premature labor. The mother may go into premature labor in placenta previa. Now, next are what are the complications the mother can face during labor. The first complication is there's a chances of early rupture of membrane, and there are chances of cord prolapse, okay, because there is no proper fixation of there is the vertex presentation is not there, so there's a chances of prolapse of cord in placenta previa. And next is slow dilatation of the cervix. Why this happens is because of the lack of ball and socket mechanism. When the head is in the lower segment, it pushes the cervix, okay, to help to dilation of the cervix. But in placenta previa, as the head is not in the lower uterine segment, instead that is a placenta, which leads to slow dilatation of the cervix. Okay, and the other complications are intrapartum hemorrhage, that is bleeding during labor, excessive bleeding during labor, and there is a chances of increased incidence of operative deliveries. Okay, the mother may have to go through operative procedures, and there are chances of postpartum hemorrhage as well. Now, what are the complications during puerperium are? The first one is sepsis. That means the lady with placenta previa is at a higher risk of developing infections in the postpartum period or in the puerperium. Okay. The second risk factor is subinvolution. That means the uterus will not go back to its normal size. Okay. And the third one is embolism. These are the three complications in the puerperium. Next, coming to fetal complications, the baby is at risk of low birth weight, okay, and asphyxia as we discussed because of lack of oxygen. There are chances of intrauterine death in fetus, and there is a risk of birth injuries associated with operative deliveries, and there is also chances of congenital malformation in babies born in mother with placenta previa. Now, coming to the most important part of placenta previa, that is how do we manage it? That's medical management of placenta previa. The first point which we keep in mind is prevention, which of course we can't prevent the occurrence of placenta previa in anyone. What we can do is we can identify the case at the earliest and limit the risk associated with it. Okay. What can be done for that is first is we have to do adequate antenatal care. All the ladies, all the pregnant ladies should get proper antenatal care and checkup to eliminate the risk factors. Second is antenatal diagnosis of low-lying placenta at 20th week with routine ultrasound. Okay, there should be a routine ultrasound at 20th week to rule out the placenta previa, and if in case we have any doubt, then there should be repeat scanning at 34th week to confirm the diagnosis. Third thing is Significance of warning hemorrhage should not be ignored. So the family and the lady should be educated about the warning hemorrhages, and if she encounters with any episodes of bleeding, she should not take it lightly and should immediately report to hospital, especially tertiary care hospital, because placenta previa cannot be managed in local setup. And the last is family planning and limitation of birth. So it has been seen that there is a chance if a lady has once had placenta previa, there is risk of the same in the consecutive pregnancy. So the family and the lady should be educated that if she had once had placenta previa, there is a risk of this to happen in future as well. So it's better to have family planning and limitation of birth methods. Now, next, so even though after you have followed all the preventive methods, in case if the lady encountered the hemorrhage at home, what should be done? The first and foremost thing is the patient should be immediately put to bed, because the more she moves around, the more will be the suppression of placenta and the bleeding will become even more worse. Okay, so first thing is the lady should be in bed immediately. Second is assess the loss of blood. How much blood loss has happened? You have to assess it, because you have to see the cloth which has been soaked, because you have to report the same to the hospital when you reach. Okay. Note the pulse and blood pressure and degree of anemia in the patient. Perform a quick but gentle abdominal examination to mark the height of the uterus. Okay. These are the things which you have to do at home when your side by is called the ambulance for shifting the patient to tertiary care hospital. Now, once the lady has reached the hospital, transferred to hospital, okay, arrangement should be made to immediately shift the patient to an equipped tertiary care hospital having the facilities of blood transfusion, emergency cesarean section, and neonatal care unit. Okay, the lady should only be taken to such hospital which has the below mentioned facilities. Okay, now the treatment of patient on admission, okay, is divided into two. First one is immediate attention, which basically focus on stabilizing the patient's condition. Okay, when the patient comes to you, a quick assessment of the patient, identify what is the condition of the patient, and the measures which has to be done to stabilize the condition of the patient comes under immediate attention. Okay, once your patient is stabilized, next you go to is formulation of line of treatment. That means in which way are you going to manage the patient. First one is expectant treatment and the second is active. We will discuss about it in our next slides. So after the immediate management, now we are formulating the treatment for the patient in expectant management. So in which condition do we go for expectant management? Okay, if the mother's HB is more than 10 grams and the duration of pregnancy is less than 37 weeks, that means the baby is still preterm. Okay, and active vaginal bleeding is absent, that is the bleeding has stopped now, and the fetal well-being is assured, that means the baby is all right. Okay, the baby is still alive and is okay inside the mother. Okay, in such condition, when the HB is more than 10 gram, the pregnancy is less than 37 weeks, and the vaginal bleeding is absent, and the fetus is okay, in this condition you can go for expectant management, or what it in layman term it means is you can wait till the baby matures or reaches 37 weeks. What should be done when a lady is under expectant management is give bed rest to the patient, do all the investigations. Okay, investigations like regarding related to patient's well-being and fetus well-being. Then periodic inspection of vulval pad to see if there is any active bleeding present. Fetal surveillance with ultrasonograph at the interval of 2 to 3 weeks should be done. Supplementary hemantonics, that means the blood supplement should be given to mother in order to replace the blood loss. When the patient is allowed out of bed, that is 2 to 3 days after the episode of hemorrhage, a gentle speculum examination is made to exclude any kind of local cervical and vaginal lesion for bleeding. Now, when should you terminate the expectant treatment? That means when should you stop the expectant management of the patient? It happens under two scenarios. The first scenario is the mother has reached 37 weeks of pregnancy. That means the baby is now sufficiently mature enough and delivery can be done without any risk to the baby. Okay, in that condition you can terminate the expectant treatment. And the second condition is if the mother's bleeding starts again. Okay, if the baby is dead. Okay, when you do ultrasound again and you find that the baby is no more, in that condition, and if the baby is found congenitally malformed, under these three conditions you can terminate the expectant management prematurely, okay, and can deliver the baby. Going to active management. Okay, when should you go for active management? The selection of cases depends upon the bleeding occurs at or after 37 weeks. That means the baby is not mature enough and you don't have to wait any longer. Second is the patient is in labor. Okay, the mother is already in labor. Third is patient is in exsanguinated state on admission. Okay, that means the patient's condition is very critical in that state. The bleeding is moderate and continuous. That means the bleeding is not getting arrested and there is a continuous bleeding. In such condition, we have to go for active management. And the last point is baby is dead or is congenitally malformed. So these are the 5 points. If the patient falls under these 5 points, that means she will not go for expectant management. Rather, you have to manage the case in active management. Now, the protocols for active treatment is, first point is vaginal examination in the operation theatre followed by low rupture of membrane. This is basically done in type 1 and type 2 placenta previa, where the placenta is not actually lying on the os. In such condition, you can try to deliver the baby vaginally by attempting low rupture of membrane and to see how this unfolds. If in between of vaginal delivery you feel that the bleeding is brisk and it's too much, then you have to immediately shift the patient for cesarean section. And the second type of management is cesarean section without internal examination, which is the best type of treatment, and it has to be done if the lady falls under type 3 and type 4 placenta. Now coming to nursing management of a patient with placenta previa, here I have listed some of the nursing diagnoses related to the condition. The first one being a risk of hypovolemic shock related to antenatal bleeding as evidenced by visible loss of blood. The second diagnosis being impaired fetal gas exchange related to decreased surface area of gas exchange at the site of placental detachment. The last one being anxiety related to unknown effect of bleeding and lack of knowledge of predicted course of management. These are few of the nursing diagnosis for placenta previa. Now, what management steps we have to follow is, the first thing is monitoring signs of hypovolemic shock, because the lady with active hemorrhage is at risk of hypovolemic shock. So a nurse has to be vigilant to identify the signs of hypovolemic shock, which are fetal tachycardia, okay, and tachycardia of mother, diminished peripheral pulses, hypotension, and increased respiration. These are some of the signs. Okay, and if you see the signs, immediately consult the physician if you see any of these signs and perform actions to minimize the effect of hypovolemic shocks. Second thing is monitoring the fetus. The nurse has to monitor both the mother and the fetus simultaneously. So what has to be done for monitoring of fetus is initiate continuous fetal monitoring to identify signs associated with reduced placental blood flow. Okay, so how you can identify that the placental blood flow is reduced is when you see in NST, that is when you do a non-stress test in the baby, you find late deceleration, and if you find non-assuring pattern in the NST, and at that time you have to contact the physician at once and let them know that the fetus condition is being compromised and it's showing these signs. And what's the next thing we have to do is promote tissue perfusion. Okay, so place the woman in a lateral position with the head of the bed flat to increase the cardiac return and thus increase oxygenation and circulation. Next thing, restrict maternal movement and activity to decrease the tissue demand of oxygen. The last one is provide simple explanation, reassurance, and emotional support to the woman to help reduce the anxiety. I hope I have made the topic easy and understandable for all of you. If you have any doubts, you can put it in the comment section. You can also write any suggestions or any advice regarding my classes. And if you want me to take any new topic, any other topic, you can also write the same in the comment section. Thank you so much.